So this is chapter 37, nursing care of patients with disorders of the urinary system. It starts on page 836. In this lecture, we'll be discussing various different disorders of the urinary tract or urinary system. In ATI, there's a ton of different chapters in regards to urinary disorders, so take a look at that. They're in chapters 53 through 59. So first we'll talk about urinary tract infections, or UTIs, and this refers to an invasion of the urinary tract by bacteria. And as we discussed before, women are at much greater risk than men, and that has a lot to do with that they have a shorter urethra, and just the proximity of the urethra to the anus and the vagina and all of the bacteria that are in those areas causes this increased risk. And then also, as people get older, those changes that happen can also cause them to be at an increased risk. So for like older men with enlarged prostates, remember that causes somewhat of an obstruction, so there's stasis of urine where they're unable to empty completely and those kind of things. And then with women, due to declining estrogen levels, this can also contribute to an increased risk of urinary tract infections. So some of the predisposing factors, stasis can be caused by an obstruction or simply not voiding enough or not going to the bathroom enough. So all of you nursing students out there who are not taking breaks and those kind of things, make sure that you empty your bladder frequently. There can also be some contamination of the perineal or urethra area, usually through fecal soiling, but also can be through sexual intercourse or infection in areas around the urethra, like the vagina or the prostate. So if there's infections there, they can also certainly cause a urinary tract infection. And then instrumentation, meaning like catheterization or scopes or other things that are introduced into the urethra, can also cause trauma or infections or bacteria to be introduced into that area as well. And then reflux of urine, usually from a faulty valve that allows the urine to reflux back into the bladder or even back into the ureters. And then previous UTIs, this is thought that they provide a reservoir of persistent bacteria that can cause a reinfection. Some of the signs and symptoms of urinary tract infections include dysuria or urgency, frequency, cloudy or foul-smelling urine, but also might include symptoms like nocturia or hematuria or back pain. But the most common presenting symptom of urinary tract infections is just a general type of fatigue. Some types of UTIs include urethritis, which is an inflammation of the urethra, and it can be caused by a chemical irritant, bacteria, trauma, or exposure to a sexually transmitted infection as well. And we talked a little bit about that during that lecture. And then cystitis, which is an inflammation or infection of the bladder wall. And this can be caused, again, by bacteria, viruses, fungi, or parasites. About 90% of UTIs are actually caused by E. coli, which grows in the perineal area and then travels up into the bladder. And then pyelonephritis, this is an infection of the kidneys, and it usually begins in the lower urinary tract, but can also start in the renal medulla and spread to the adjacent cortex. So some of the data collection that you want to do for urinary tract infections is what are their signs and symptoms? Are they having the general malaise, flank pain, fever, chills? How long have they been having these symptoms? What does their urine look like? Do they have any predisposing factors such as obstructions or strictures or a history of stones or reflux? Have they had any recent scopes or caths or surgeries? And then certainly we're going to send their urine for urinalysis and culture results. So has that already happened? If it has, we're going to want to get those results. If it hasn't already happened, we're going to be wanting to send a urine for that testing. So some of the nursing diagnosis: acute pain related to inflammation of the urethra, bladder, or other structure, whichever structure is actually having the problem. Impaired urinary elimination related to the frequency or nocturia, dysuria, or even incontinence. Risk for injury related to sepsis or kidney disease or kidney injury. And then knowledge deficit related to their diagnosis, proper hygiene, and other things. Some of the care we're going to provide: monitoring their symptoms, certainly monitoring their intake and output. We're going to give them some pain control. A lot of times I see in practice antispasmodics like pyridium used. That's the one that turns the urine that fluorescent orange color. And then we're going to do some teaching around lots of different things, but we certainly want to make sure that we teach them about taking all of their antibiotics and remembering even until they're gone. I mean, not until their symptoms have resolved, because a lot of times they'll start feeling better in 24 to 48 hours, but we want them to take their antibiotics until all of the antibiotics are completely gone, because stopping the antibiotics too early can allow the infection to continue, but it also can create resistant strains of these bugs as well. And then prevention, there is a box 37.1 on page 841. It talks about making sure to void frequently, voiding after intercourse, good hygiene habits, and then fluid intake as well can help out with prevention. I'm going to switch gears and talk a little bit about obstructions. And obstruction of urine flow is always significant. This is defined as an interference in flow at any location in the urinary system. And what happens is the backup of urine destroys the kidney from the increased pressure that causes dilation and thinning of the renal tissue. And then the renal blood supply is compromised, and eventually the renal tissue is destroyed by all of the compression. So this is a picture of a stricture. You can see it there on the bottom kind of right-hand side of the slide. But urethral strictures, the urethral lumen has narrowing, usually due to scar tissue. There's an increase in occurrence in young adults nowadays, as the gonococcal and chlamydial infections can result in strictures, so that would be something that you might want to look for in a health history if you're faced with a patient that is younger that is having a stricture. Renal calculi or renal or kidney stones. These are hard, generally very small stones. When somebody has a kidney stone, it is referred to as nephrolithiasis. And we're going to talk a lot more about kidney stones next. All right, so renal calculi or nephrolithiasis or kidney stones, whichever one you want to call it. Here, what's happening is that there's urinary salts that settle out. Usually calcium oxalate is the most common, but they can certainly, once the stone is passed and collected, they can analyze it and see what it is made of so that they can better prevent stones in this person in the future. So symptoms occur when the stone becomes impacted in the urinary tract, and it can cause a lot of pain, discomfort, obstruction in the system, and those kind of things. So what is the etiology? So causes include certainly a family history of stones, chronic dehydration, which can lead to more concentrated urinary salts, infection, as this is can create or make the nucleus for the stone formation, so everything kind of will go around one of the bacteria and create the stone. Immobility from urinary stasis and from calcium leaving the unstressed bones. So the increased calcium in the blood is then filtered through the kidneys and can cause these stones. Men are at greater risk than women, and there are dietary and geographical factors as well. There is a box on page 843, it is box 37.3, that talks a little bit about nutritional notes that can be helpful with kidney stones. So some of the signs and symptoms, flank pain, and this can be excruciating type of flank pain. It is not uncommon for the pain to actually radiate from the flank down into the genitalia. So they may complain of a lower abdomen pain or pain in their groin. That's fairly common. Or with men, sometimes they will complain of testicular pain as well. So renal colic, also pretty common. Dysuria. Costovertebral tenderness, or also known as a Murphy's punch sign. This is where they percuss the flank, which causes pain because tapping on the back causes this disturbance in the inflamed tissue, so there'll be kind of a pain back in the flank that's induced from it. And then hematuria, or blood in the urine, frequency, urgency, enuresis, or the inability to control urination at all, can happen as well. And then certainly GI upset, folks will have nausea and vomiting around this as well. So diagnosis the top ones on this slide, so like kidney, ureter, bladder, or KUB, which is an x-ray, the intravenous pyelogram or IVP, and renal ultrasounds, these can all identify the location of the stone, the size of the stone, those kind of things. Then we also may get a urinalysis, and it may have gross or microscopic hematuria from the trauma that's happening within the urinary tract. It also can have the presence of crystals or urinary pH, which may indicate the type. We could look at urinary pH, which may indicate the type of stone that it is or what it's comprised of. So some of the interventions, small stones, so stones that are about 5 millimeters or smaller, can usually pass all on their own. Larger stones generally will not pass without some type of intervention. We're going to increase IV fluids. We're going to give them lots of them to hydrate and flush out the stone. Certainly pain control is going to be a top priority. A lot of times what I see work in practice are medications like Toradol, which is an anti-inflammatory drug, works excellent for the inflammation within the system and helps significantly with pain. Certainly we're not going to not give narcotic types of pain relievers, but we usually use the Toradol as a first-line type of drug and then move to giving narcotics as well. We also give thiazide diuretics or allopurinol, which is used to treat calcium types of stones by reducing urinary calcium secretion. And then they may require something like lithotripsy, which is a procedure where shock waves are used to break the stone into smaller fragments so that it is able to pass. So some folks may require surgery. The procedure will depend on the location of the stone. Cystoscopy, where they put a scope directly into the bladder, may happen. And then cystolithoplaxy is where an instrument is inserted through the urethra to the bladder, and then it crushes the stone, and then the stone is washed out. They also may need a cystotomy or a urethrotomy or a nephrolithotomy with a placement of a nephrostomy tube. These are open types of procedures where a type of incision is required. The nephrolithotomy can be done percutaneously through the skin, where the scope is inserted into the kidney to the back, or to break up the stone, and then they'll irrigate the renal pelvis. The nephrostomy tube is usually left in place at first to prevent some of the stone fragments from passing through the rest of the system. So prevention with foods, low oxalate type of diet, so restricting foods like beets, rhubarb, spinach, cocoa, instant coffee, those kind of things. But there might be other types of dietary restrictions depending on the type of stone. Certainly hydration, we want to prevent dehydration, want to make sure that people stay hydrated. Exercise, which promotes excretion of stones and also reduces that calcium reabsorption from being sedentary. Some of the complications around renal stones include urinary tract infections related to obstruction. Remember that stasis, or the inability to get the urine out of the system, can cause it to back up and cause urinary tract infections. And then certainly hydronephrosis, which is retention of the urine up into the kidney, and we'll talk more about that in a lot more detail here in just a bit. Some of the nursing diagnoses that you're going to see around kidney stones: acute pain, which is related to the presence of an obstruction or movement of the stone causing trauma within the urinary system. Risk of infection, which we just kind of talked about, related to introduction of bacteria from obstructed urinary flow and or instrumentation if we're having to do some type of procedure to this person to remove the stone. And then knowledge deficit or deficient related to the lack of knowledge about prevention or reoccurrence or diet or even signs and symptoms or other things about kidney stones themselves. So nursing care, we're going to monitor their signs and symptoms. We're going to strain all of their urine because we want to collect the stone if possible and send it for urinalysis, so that way we know what the stone is comprised of and we can better help the patient to prevent having stones in the future. That will help with dietary and other things that we might need to change for them. Sorry, excuse me. We're going to monitor intake and output. We're going to certainly provide pain control and hydration, and then some teaching to maintain fluid balance. We want them to be drinking or have fluids in about 3 liters a day. We're going to go over any medications that have been prescribed, and then we definitely want to talk to them about signs and symptoms of infection or when they would want to follow up with their doctor. Alright, so now hydronephrosis, and this is the distension of the renal pelvis and calces resulting from an obstruction in the urinary tract. And here the kidney enlarges as the urine collects. What we're going to do here is treat the cause. So is it a stricture? Is it a stone? Is it a tumor? What is causing the urine to not be able to flow out of the system? If it's not corrected, it can certainly cause damage to the blood vessels and renal tubules, sometimes in just a matter of hours. So signs and symptoms: if the onset is gradual, the patient may be asymptomatic at first. Patients with obstructions will commonly develop a urinary tract infection, so may experience frequency or dysuria or urgency. And as the problem progresses, they may experience back pain or flank pain. Then they'll eventually develop symptoms of chronic renal failure. And again, we'll talk a little bit more about chronic renal failure a little bit later in the lecture. So here we want to treat the cause. So the priority is to identify the problem or what is causing the obstruction and fix it. Initially, we may put in a urinary catheter, and then we may have to go in and put in stents or a nephrostomy tube again. So some folks may require surgery here. We're going to monitor intake and output. It should be monitored really closely to ensure that there's no worsening of the urinary retention. And then we want to make sure that we do not clamp nephrostomy tubes. This is huge. This causes, when you think about it, there's already some type of obstruction happening. We finally get the tube in so that the urine is able to flow out. If we clamp the tube, then we're causing a mechanical obstruction. So we're causing the problem at that point. So next, we'll talk about cancer of the bladder. This is the most common urinary tract type of cancer. Men are at greater risk than women. It usually starts in the inner lining of the bladder, and it can affect only the lining, or it can certainly be a lot more extensive, and it can move into or affect the muscle wall. There is certainly a greater risk of people from ages 50 to 70. It's very rare in people that are younger than 20. There is a significant link between smoking and bladder cancer, where people that smoke are 2 times more likely to get bladder cancer. And then certainly there can be industrial types of pollutions that folks are exposed to that can also cause problems with bladder cancer. Common sites for metastasis for bladder cancer are the liver, bone, and lungs. So early signs and symptoms are painless hematuria. Bleeding can initially be intermittent, which causes people to delay seeking treatment because it will come and go. So they'll think there's a problem, and then it'll go away, so they think everything's fine, and then it'll come back and so forth. And then later on, pelvic pain, lower back pain, dysuria, or inability to avoid urinary retention. There also can be fistula formations between the bladder and adjoining structures like the vagina or the bowel. So diagnosis, they can do a urinalysis. Sorry, I can't pronounce this one. Telomerase. This is an enzyme that is found in the urine, which has been found to be about 90% effective in detecting bladder cancers in both the early and late stages. They can also do collect urine for cystology, or looking for cells, or the cells within the urine, or send it for a urine culture. Cystoscopy and transurethral biopsy can be done, or also IVP. Therapeutic interventions, so chemotherapy, there are multiple different drugs that are out there, and so it's just going to depend on the doctor and the patient and their health status and those kind of things, which kinds of medications they choose to use. The Bacille-Clement-Guerin vaccine is used to prevent reoccurring tumors and is instilled within the bladder. They can also use photodynamic therapy, and this is where drugs are given that make the cells sensitive to light, and then light is applied to the area, and it kills the cancer cells. So continuing with therapeutic interventions, there are different types of surgery that can be done as well. So there can be cystoscopies and pylograms with fulguration, and this is destruction of the tissue with electrical current to burn off the cancerous tissues. Laser interventions are along that same lines. There can be robotic, laparoscopic, radical cystectomies where there's bladder removal that happens here. And then certainly urinary diversion types of things that can happen, and we're going to talk about those next. So urinary diversion means that the urine leaves the body in a different manner. There are continent and incontinent types of diversions. An ileal conduit is an incontinent diversion, and what it does is it uses a piece of the ileum of the colon, which is removed, just a little section, and then they flap one of the pieces of skin, closing off one of the ends, creating kind of a long pouch, and then the ureters are attached to it on the backside or on the sides. And then the other end of this little tube that is created, or pouch that is created, is brought through the abdomen to create a stoma. So the urine from the ileal conduit will contain mucus. This is a normal finding because it comes through the ileum, which normally secretes mucus. So this type of diversion almost continuously drains urine, so the patient will need to wear some type of ostomy appliance. So here, with the continent urinary diversions, there's many different types of ones that you'll see, cock pouches, Indiana pouches, Maine's pouch, Florida pouch, those kind of things. So there are, here a piece of the ileum is used to make a reservoir for urine. The ureters are connected to the reservoir, and then a nipple valve is constructed. So the patient here will need to insert a catheter, usually at 4 to 6 hour intervals, to empty the reservoir. So, orthotopic bladder substitution. So this is the creation of a new bladder or a neobladder, where the ureters and urethra are implanted into the new bladder. There are various different types of bladder substitution surgeries, including Studer pouches or hemicock pouches or ileal W neobladders. Incontinence may be an issue with this type of surgery, and intermittent catheterizations might be needed. So for nursing care, we need to get a wound ostomy continence nurse to consult with these types of patients. We're going to monitor for complications related to surgery, just like any other type of surgical patient. We're going to teach strategies for prevention of shock, pneumonia, DVT, and then we're going to teach about reporting complications. So we want them to know what complications they should report immediately. So kidney cancer, some of the risk factors again include smoking, obesity, and hypertension or long-term kidney dialysis. Certainly if there's radiation exposure or exposure to things like asbestos or industrial types of pollutions, this can also increase the risk. Most patients that get kidney cancer are between 50 and 70 years of age. This disease does not often have early signs and symptoms, and may only be detected after it has metastasized to another area. So more than like 50% of the tumors that are renal tumors are found incidentally when the physicians and everybody are looking actually for something else. So later signs and symptoms, hematuria, dull pain in the flank, and a mass. These are the three classic symptoms of kidney cancer. Again, symptoms of metastasis may be the first evidence of kidney cancer and may include things like weight loss, cough, bone fractures, liver abnormalities, and increased weakness. So some of the diagnostic procedures that you're going to see here are IVPs, cystoscopies and pyelograms, ultrasounds, CT scans, MRIs, and then renal biopsies. This is where the definitive diagnosis is actually made by getting that tissue sample and analyzing it. So they may need to get a radical nephrectomy, which is removal of the entire kidney and the adrenal glands, all the surrounding structures as well, so fat, fascia, and lymph nodes. They can do a nephron-sparing surgery where only the tumor is removed and they can leave the kidney in place. Certainly with all types of cancer, there can be radiation therapy, immune therapy, and chemotherapies that might be used after surgery as well. So nursing care, post-op care is similar to care for any type of major surgery, remembering that the kidney is a very vascular, so you definitely need to be monitoring for signs and symptoms of bleeding. We want to monitor urine output and monitor for any types of changes that might be happening in the urine. We're going to provide education, pre-op and post-op care as well. We're going to monitor for shortness of breath or diminished breath sounds on the affected side or the side that had surgery, those kind of things. Because pneumothorax can occasionally happen after a nephrectomy. So we want to monitor for those things. So renal trauma, there are many causes of renal trauma, including motor vehicle crashes, sports injuries, falls, gunshot wounds, stabbings, all of those kind of things. Flank pain and hematuria may be present. We're going to treat the injury. Treatment depends certainly on the extent of the injury and can range from bed rest to surgical interventions. Some of the diagnostic testing would include urinalysis. We might do a CT scan or a IVP, MRI, or ultrasound as well. So again, we're going to be monitoring intake and output, vital signs. We're going to be giving IV fluids and providing pain control. So polycystic kidneys, this is where there are multiple cysts in the kidney. It is a hereditary disease, and these cysts form within the kidney, and they can eventually replace normal kidney structures, which obviously is very problematic. Some of the signs and symptoms initially will be this dull heaviness in the back or flank, hematuria, certainly hypertension or urinary tract infections. People with polycystic kidneys are also prone to aneurysms in the brain and also of diverticulosis in the bowel. Usually this disease is diagnosed by ultrasound. There's no treatment to stop the progression. Some complications include urinary tract infections and headache secondary to the high blood pressure. Patients with persistent or severe headache should certainly be instructed to seek medical attention because of that risk of aneurysms that come along with this disease. And because it is a hereditary disease, patients should be counseled about the risks of their children inheriting it, so they should probably have counseling prior to deciding whether or not they would like to have children. So diabetic nephropathy, this is a long-term complication of diabetes. It's the most common cause of chronic kidney disease, and it may cause it causes damage to the small blood vessels within the kidneys. Atherosclerotic changes decrease blood to the kidney, then abnormal thickening of the glomerular capillaries damage the glomerulus allowing protein to leak back into the urine. Smaller doses of insulin will be needed as the disease progresses because the kidneys normally degrade insulin, so because it cannot be broken down or excreted, smaller doses of insulin will be circulating a little bit longer. What else? Let's see. High blood pressure certainly accelerates the renal damage, so we want to be able to control that. As diabetic nephropathy progresses, urinary output will decrease, the wastes start to build up, and then chronic kidney disease develops. So early interventions will be to control blood glucose levels and blood pressures. They can be given ACE inhibitors or angiotensin II receptor blockers to slow the decline of the glomerular filtration rate and microalbuminuria. So they may have restricted protein diets as well. Later, as the disease progresses, they may need to be on dialysis or be put on a list and get a kidney transplant. So education is really important here. It's really important to teach patients about monitoring and adequately controlling both their blood glucose levels and blood pressure. Nephrotic syndrome, here a large amount of protein is lost in the urine, and this is due to increased glomerular membrane permeability, which decreases albumin and total protein, which maintain fluid in the vascular space. This decreased protein causes a leakage of the fluids out of the vascular space, so patients will have edema. It can cause ascites and widespread edema if the protein levels are really low. And then if that's not enough, the liver will then start producing lipoproteins, which increases serum cholesterol levels and triglycerides, and then loss of immune globulins may lead to an increased susceptibility to infection. So treatment is focused on the cause. There's certainly sodium restrictions to control edema. Diuretics and also lipid-lowering drugs might be given as well. So nephrosclerosis, here hypertension damages kidneys by sclerotic changes, resulting in a decreased blood flow to the kidney. The body will try to compensate with vasodilation in the nephrons to increase the blood flow to the glomerulus, which will make an increased pressure and filtration. But this high pressure will eventually weaken the vessels and cause hemorrhage. Some of the signs and symptoms that you'll see is protein in the urine, and also hyaline crystals, or not crystals, casts in the urine. Therapeutic intervention is around antihypertensives, so really lowering the pressure in the system. To reduce, what they'll do is work on reducing blood pressure, low sodium diet, and meds, and then the patient may also require dialysis. So nursing diagnoses that you'll see here are generally impaired health maintenance. Glomerular nephritis is an inflammation or inflammatory disease of the glomerulus, where the glomerulus becomes more porous, which allows proteins, white blood cells, and red blood cells to leak into the urine. So causes, there could be an acute post-streptococcal type of problem, which is following like a strep infection of the throat or skin. There are many different causes, including immunological abnormalities, toxins, vascular disorders, and also systemic disorders. Goodpasture syndrome is an autoimmune response where the body forms antibodies against its own glomerular basement membranes and attacks it. And then chronic glomerular nephritis occurs over years as a result of glomerular inflammatory disease. So some of the signs and symptoms can be oliguria, hypertension, electrolyte imbalances, edema. This can be fairly extensive. It can be around the eyes or periorbital, in the face. It can progress to ascites and extend to the lungs and extremities. And then they may also have flank pain as well. So diagnosis, the BUN and creatinine may be elevated. For urinalysis, there may be white blood cells, red blood cells, albumin, and casts in the urinalysis. Urine can be a dark cola-colored from old red blood cells being in it. It also may be foamy because of the protein urea. Also, they might do ultrasounds, x-rays, or biopsies to determine any abnormal kidney shape or size, to look at blood flow, look at inflammation or scarring of the glomeruli. Therapeutic interventions. Most cases will resolve spontaneously, but some progress to chronic kidney disease. So treatment is primarily symptomatic. So for nursing care, we want to monitor vital signs. We're going to give them symptom type of support. So like I said, we're going to treat the symptoms that they're having. We're going to want them to rest. We're going to do fluid, sodium, and protein restrictions to control edema. And then we're going to do education regarding prevention. Protein intake is limited if the kidneys are not filtering protein waste products. And then antibiotics for strep infections should be taken for prevention as well. So acute kidney injury, this is a sudden loss of kidney function. Azotemia is where the waste products accumulate within the system. Then they could be oliguric, and then they may recover. Most recover if diagnosed and treated early. These diseases or these injuries are classified as pre-renal, intrarenal, or post-renal related to the cause of the injury, and we're going to talk about each one of those now. So pre-renal failure, this is before the kidney, so this is a decreased blood supply to the kidney. Intrarenal failure is inside the kidney, so this is damage to the nephrons. And then post-renal failure is after the kidney, so an obstruction that blocks flow of the urine out of the body. So there are many different nephrotoxins, and things that are toxic to the kidneys are called nephrotoxins. And these can include contrast dyes, medications, or other chemicals, such as insecticides or lead paints. We've talked about, I think with almost every lecture we talk about with medications, a lot of them have a lot of troubles or problems with causing nephrotoxicity, so we have to really watch renal function. And then with the last lecture, when we were talking about urinary systems and talking about those intravenous pyelograms, or anytime they're injecting dye, like for CT scans or things like that, that we're really monitoring kidney function closely before we do those things to make sure that we're not causing any more trouble, because those medications could be very nephrotoxic. So prevention, and here we talked about, checking serum kidney function levels with BUN and creatinine prior to giving dyes or other medications, certainly hydrating before and after they get any type of contrast media, monitoring peak and trough levels of drugs that can be nephrotoxic. Those are just some of the strategies that are used to reduce the risk for having troubles from these nephrotoxic types of substances. So the three phases of acute kidney injury, the first being oliguric, where less than 400 milliliters of urine is produced in 24 hours. Usually occurs from 24 hours to 7 days after the initial phase. It can last 2 weeks to several months. Fluid is retained. Electrolytes become imbalanced, and waste products are not excreted. Then the diuretic phase, where the patient is actually producing 1 to 3 liters a day. The kidneys are still unable to concentrate urine, so dehydration and hypotension occur. This phase can last 1 to 3 weeks. And then the recovery stage begins as the glomerular filtration rate increases. Waste product levels start to decrease greatly within the first 2 weeks of this phase, but it can take up to a year for the body to fully recover. So therapeutic intervention, prevention of permanent damage is certainly the goal of treatment here. So identifying the cause and treating it is going to be very important. Supportive care to restore fluid and electrolyte imbalance and resolving the obstruction. Some patients may require dialysis or continuous renal replacement therapy, which is also known as CRRT. So CRRT removes fluid continuously along with hemodialysis. It removes fluid and solutes in controlled, continuous manner in unstable patients. Blood flows through a hemofilter, and then the excess fluids and solutes move into a collection bag. So that's how that works. All right, so chronic renal failure. This is a progressive and irreversible chronic problem, and it can certainly affect every single system within our body. Some of the causes are diabetic nephropathy, nephrosclerosis, glomerulonephritis, or different types of autoimmune diseases that can happen as well. So here, a large portion of the nephrons are damaged. Patients can be without symptoms until more than 50% of the nephrons are damaged. It's progressive. Renal insufficiency starts to happen when about 75% of the nephrons are lost. Here you'll start seeing anemia and the inability to concentrate urine. In the end stages, 90% of the nephrons are lost. They may still make urine, but are not really filtering out waste products. And then you'll start seeing uremia or urea in the blood. And again, eventually it affects all the body systems, and if it is left untreated, the patient will definitely die. Symptoms of chronic kidney disease include fluid accumulation, electrolyte imbalances, waste products are retained within the system, acid-base imbalances, and anemia, and all of this should make absolute sense to you when we're talking about all of the things that the kidneys do as far as filtering of waste products, definitely with acid-base balances and the secretion or retention of hydrogen ions or bicarb, anemia with the production of erythropoietin, and those kind of things. So this slide just kind of provides a visual of the problems that can happen throughout the body system, and this is on the top left-hand corner of page 858. So renal insufficiency and early kidney disease are treated based on symptoms with restrictions in diet, fluid intake, and then medications as well. Diet, you're going to see increased calories they want them to take in to maintain weight and energy, decreased protein to limit nitrogen intake, decreased sodium to minimize fluid retention. They're going to have a potassium restriction because of the kidneys not being able to eliminate it. Increased calcium related to, they'll have that poor absorption related to faulty vitamin D activation. Remember, the kidneys activate vitamin D as well. And then most of the patients are given vitamin supplements as well when they're on restricted diets, so you'll see that as well. So medications, diuretics to increase output, antihypertensives to lower the blood pressure, phosphate binders to lower phosphorus levels, calcium and vitamin D supplements to help maintain calcium levels, and then K-exolate, which will help to reduce potassium levels. Dialysis is started when the patient develops symptoms of severe overload, or they have a high potassium level, acidosis, pericarditis, they're just not doing well, so vomiting, lethargy, fatigue, or other symptoms that of uremia. What dialysis really does is it's an artificial kidney that removes the waste products and excess water from the blood. And dialysis can be accomplished either through hemodialysis or peritoneal dialysis. So if they're going to have hemodialysis, this requires a permanent vascular type of access to be inserted. Temporarily, while they're waiting for a maturity of one of these AV fistulas or AV grafts, they can insert a temporary type of device that can be used until these other grafts are developed. So you'll see people with things like Maherkers or other types of catheters that they'll use for dialysis until these other vascular accesses can be determined. So to assess a vascular access device and to care for it, we're going to feel for a thrill and hear the bruit to check for patency. There is one of these patients, I think, right now at Granada, so if you are there currently in a clinical group, ask Vianne to maybe check this patient out, and when you get there, if you're at Mad River, when you get to Granada in the next couple of weeks, see if that patient is still there so that you can also check that out. Post-operatively, we're going to do neurovascular checks and pain control. We're going to encourage range of motion exercises and then elevate the extremity. Blood pressures and IVs should be completely avoided in the extremity that has the access because we don't want to damage the site. So peritoneal dialysis, this is continuous dialysis that is done by the patient. So the peritoneal membrane is a semi-permeable membrane. And here fluids can cross, or waste can cross back and forth between these fluids from the blood. So they'll have a peritoneal catheter and they will connect to it, and the exchange process is where they have a fill time, or they fill, then they have a dwell time, and then they drain. So they fill the peritoneal cavity with a sterile dialysate solution. That solution is then left to dwell in the abdomen, the abdominal cavity for several hours, where that exchange takes place, and then that solution is drained out. One of the major complications with peritoneal dialysis is peritonitis, which can be life-threatening. The major causes cause of peritonitis in this group of patients is poor technique. So it's very, very important to teach the patient proper technique and sterile technique when they're attaching to their site. One of the first signs is abdominal pain. We want to talk to patients about signs and symptoms of peritonitis so that they will get or seek treatment immediately if symptoms occur. So kidney transplant can happen. This can be with a living related donor or a cadaver donor. The advantage to transplant is that it reverses many of the physiological changes and the patient is no longer dependent on dialysis. Tissues and blood types must be matched to reduce the risks of rejection, but the patient is going to have to take anti-rejection drugs for the rest of their life. And even though these tissue and blood type matches are made and they're very carefully analyzed, and the patient is taking anti-rejection drugs, the body may still reject the new kidney, and if this happens, the patient would then have to go back on dialysis. Some of the nursing diagnoses that you'll see: excess fluid volume, impaired skin integrity, activity intolerances, risk for injury and infection, and certainly imbalanced nutrition, less than body requirements. Some of the things that we're going to do is monitor weights, and this will be done daily. We're going to monitor intake and output, and this will be very strict, so they really, really want to keep track of what's going in and what's going out. We're going to monitor fluid restrictions, and then for signs and symptoms of fluid retention. We're also going to monitor for electrolyte imbalances, so looking at all of those different magnesium, potassium, phosphorus levels. We're going to monitor dietary restrictions, and then monitor for dysrhythmias, because we know that when our electrolytes get out of whack, then we start having problems with electrical conduction. So it'd be very important to monitor for dysrhythmias as well. So we're also going to monitor for waste product buildup. We're going to provide oral care to decrease the bad or metallic taste that's in the mouth. Bathe the patient with tepid water to remove urea crystals from the skin if it's gotten that far, and applying lotion. We're going to assess for signs and symptoms of infection and try to protect them from any injury. We're also going to assess for impaired hematological function, because of that decreased red blood cell production and impaired white blood cell function that can happen as well. So we will have time to discuss any questions that you might have in regards to this lecture on Wednesday. You may also post any questions in the discussion forum. You can always email me via the message board or redwoods.edu account, which is Jessica _Howard@redwoods.edu, or you can call or text me, or you can make an appointment to meet with me as well. Want to make sure that you're clear on all of the information, so if you have questions, please let me know. For the discussion forum, I just want you to post one fact regarding one of the topics from this lecture, and then I want you to post one question about the lecture topics. And then I want you to just answer one question that is posted by one of your peers. This will not be due until Sunday, the 23rd at 5 o'clock, so you should have plenty of time to take a look at this lecture and then make your post on the discussion forum. Thanks. If you have any questions, let me know.